Welcome, everyone. Thank you all for joining us today for today's presentation as part of the Mercy Specialty Clinic Seminar Series. My name is Meg Elhout, and I have the privilege of working with an outstanding team of surgeons, advanced practice providers, and staff as the manager of clinic operations for Mercy General Surgery, Bariatric Surgery, and Acute Care Surgery clinics. I have the pleasure today of introducing one of those outstanding surgeons to you today. Please help me in welcoming Dr. Hassan. Dr. Hassan has been with Mercy for nearly a decade, and he has established himself as a skilled general and colorectal surgeon. His clinical expertise includes anorectal surgery and surgical management of benign and malignant colorectal diseases. And what sets Dr. Hassan apart is his specialization as one of the only fellowship-trained colorectal surgeons in the region, making his insights particularly valuable. As we move through today's presentation, before I hand it over to Dr. Hassan, just make sure you keep your mobile devices handy at the end of the presentation. There will be a few QR codes. Dr. Hassan will have his information up there in a QR code. And then you will also need to scan the QR codes for claiming your CMEs and CEUs. So thank you once again for being here, and without further ado, I will pass the podium over to Dr. Imran Hassan.
Good afternoon, everybody. Thank you for everybody who's online and in person. Where the room is set up, the screen is that way, the camera is that way, so it may look like I'm not looking directly at anybody, so just bear with that. Meg, thank you for that kind introduction and everything you do for our clinic and make sure things run on time, as always. As Meg said, I'm a colorectal and general surgeon. I primarily deal with colon and rectal cancer for malignancy as well as anal cancer, and then take care of other benign conditions like inflammatory bowel disease, Crohn's colitis, ulcerative colitis, diverticulitis, and other anorectal problems like fistulas, abscesses, and hemorrhoids. So I've been here 10 years. It's been a privilege taking care of patients at Mercy, and hopefully I know some of the providers who are online, and those who don't know me will get to know me a bit more as we go through this presentation. So today we'll talk about one thing that we see very commonly in clinic, both in medical management and in the surgical management, which is diverticulitis. And we'll try to break this topic or this session into like 3 parts. Just for timing, I'm going to take about 40 minutes, so there are 20 minutes at the end for questions, answers, and catch up. So I won't take the full 1 hour, so we stay on time for the rest of the day. So 3 main parts of the talk. One is talking about the burden of disease of diverticulitis and diverticulosis, pathophysiology, and the spectrum. And I think that's important to understand some of these key concepts when we get into the medical management and the clinically relevant questions, which is the second part that come up in the medical management. And then the third part is talking about decision-making in diverticulitis and diverticular disease, and when do we do surgery. And that will be the third major part of this talk. So 3 main parts, and we'll go through each of one of them, kind of do a summary at the end. So one thing that's going to be unique about this talk is the paradox of knowledge, that the more we understand about diverticulosis and diverticulitis, it seems like the less we know. Most of the guidelines or decisions we make in surgery are based, or in medicine also, based on evidence and trials that figure out what is the best thing and what is the best treatment option. And unfortunately, in diverticulitis, or what you would think is such a common disease, we don't know that much. And a lot of things that we thought were right are not totally accurate, and a lot of things we're still learning. So this will come up and be a recurring theme of this talk, and we'll try to add some clarity and some understanding despite a lot of uncertainty, so we don't leave you kind of all confused and muddled at the end of this talk. So the first part is the burden, pathophysiology, and spectrum of diverticular disease, exactly what is it all about. So diverticulosis are just air pockets in the colon. That's the simplest word I explain to patients with, that they get in any part of the bowel, but it's more common in the sigmoid colon, and it's where the colon is weakened, the blood vessels enter into the bowel wall, and that's where these pouches occur. And they're technically false diverticula, meaning that they only have a part of the wall involved and not all 3 layers of the body of the intestine. It is very common, and it's obviously hard to diagnose because we only diagnose in people who have symptoms, and a lot of people may have no symptoms and still have diverticulosis. But in general, 60% of the people above 60 will have evidence of diverticulosis in their colon, most likely, usually in the sigmoid colon. So a common condition, it gets older, increases with age, so 70% is higher incidence in people in their 70s and 80s and so on and so forth. But what is interesting is that it does cause a lot of burden on the healthcare system. There are about 500,000 at hospital admissions and about 9 billion direct costs from management of diverticulitis. And in context, this is about the same amount of hospital admissions that we see for cholecystitis. So it's kind of up there in terms of GI conditions for which patients go to the hospital. So it's not an insignificant number or an insignificant amount of healthcare costs that goes into managing this condition. What we do know that the incidence of diverticulitis has increased over time, and it is not absolutely sure why we're seeing more diverticulitis, but the number of patients that are going up has increased. But this increase is greater in patients who are less than 50, and that is unique in the last 10 to 20 years that we're seeing people who are younger and younger, people in their 20s, 30s, and 40s are being more commonly seen with diverticulitis, and that's the proportion or the group in which the number of cases are increasing over time. So that definitely is one shift that we've seen, but we don't have a good explanation, but it's a reality. Now, one thing, what everybody thinks and patients get confused between what diverticulosis and diverticulitis is. So diverticulosis is just the presence of having the diverticula, and the diverticulitis is when they become symptomatic, and that's a whole spectrum that we'll get into. But in general, we used to think that people with diverticulosis will get diverticulitis at a fairly high incidence or rate, almost 25%. Like 1 in 4 people with diverticulosis will get diverticulitis. This is based upon old studies that are almost 50 years old, but in modern studies and modern imaging, we know that risk of diverticulitis is much lower, so it's less than 5%. So all the people who have diverticulosis, only 5% of the patients get diverticulitis. That number is very small, and that becomes relevant as we go into this presentation. So this is the natural history of diverticulitis, and it's worth spending some time on this. I don't have a pound pointer, so for people on Zoom, they'll just have to kind of imagine. So most people will not have diverticulosis. Then 60% of the people above 60 have diverticulosis. Of those people who have diverticulosis, less than 5% will get diverticulitis, which is not a large number, but considering the number of people who have diverticulosis, it's not an insignificant number. And then of those people with diverticulitis, they can go in 3 different paths. They can have complicated diverticulitis, which does more. They can stay on the uncomplicated pathway and just have uncomplicated diverticulitis, or they can have uncomplicated diverticulitis and then move to complicated diverticulitis. So what this kind of shows that diverticulitis is a spectrum. It's not a one size or not a binary. Either you have it or you don't. Either you have complicated or you have uncomplicated. They kind of go back and forth. And the lower picture just is a representation of the proportion. The bigger the size, the more proportionate of patients in that category. So majority of the patients with diverticulosis are asymptomatic. And then there's a very small sliver at the very bottom that goes to surgery. And then between that, there are people with complicated and uncomplicated diverticulitis. So it's a common problem, it's a big problem, but not everybody with diverticulosis will get diverticulitis. So that's one thing to reassure patients. And of the patients who do get diverticulitis, not everybody will have complicated or uncomplicated, but most people will have uncomplicated. But despite that division, there's a lot of overlap between. So the first question that everybody wants to know, then why does this happen? Why do people get diverticula, and why do people have get diverticulitis? And that's a complicated question that we don't totally understand. And partly of that is because it's a combination of several things. It's a combination of the patient, genetics, diet and lifestyle, and then external factors like medication and the bowel itself. So there are 4 or 5 big categories that can influence it. And then how those categories interact with each other is even more complicated in predicting who gets diverticulitis and who gets diverticulosis. But these are the 4 major kind of players in the pathophysiology. Now, if you look at genetics, we know that it does run in families, but how hereditary we don't really understand because that can be influenced by diet and other factors. But if one twin gets it, the other twin is more likely to get it. So that's the closest evidence we have that it does have a hereditary predisposition. In terms of risk factors or dietary factors, alcohol, smoking, red meat, obesity, and dietary fiber have all been shown to be associated with diverticulosis. And that's part of the reason why this whole fiber thing came up is that and these are studies from the 1940s that somebody looked at people who lived in Africa and had high fiber diet were less likely to have diverticulosis, well, versus the westernized diet, which when around that time was becoming more refined because of the Industrial Revolution and was more processed and had less fiber, incidence of diverticulosis was going up in the Western population. So based upon that logic of those studies, people figured that fiber or dietary fiber was critical to the formation of diverticulosis and subsequent diverticulitis. But again, these are studies back from the 40s, but still to some extent hold true that dietary fiber has something to do with the incidence of diverticulosis. But that's just one part. And the other things that go into it, like the microbiome, it's influenced by the patient's diet, and other factors like the bowel wall and the inflammation. So all of those things kind of interact together, different degrees in different patients that comes up with underlying cause. So for something that's relatively simple, you would think we would figure it out. We know kind of how people get cancer, but we don't really understand how people get diverticulosis. So more to learn. So one, it's complicated enough to understand why we get diverticulosis, but then to try to figure out how to differentiate complicated and uncomplicated diverticulitis is even more complicated. So I'll try to make it a bit simple. So there's one on the left side, uncomplicated diverticulitis, which is usually patients who have left lower quadrant pain, fever and leukocytosis, and then have some inflammation in the sigmoid colon. So that would be uncomplicated diverticulitis. And then on the other side spectrum, you can have people who have an abscess, you can have a perforation that can lead to sepsis, you can have a fistula to the bowel or the bladder or the femoral organ, you can have a stricture or a narrowing that can cause a blockage, and then you can have bleeding. So those are the symptoms of complicated diverticulitis. But even in them, a lot of spectrum, like an abscess, you can get a 5 centimeter abscess or you can get a 5 millimeter abscess, and those are not the same, even though it's under the category for complicated diverticular episode. So a lot of overlap, and a lot of great possibilities. So coming back to the slide we talked about, most people with diverticulitis will simply stay with having uncomplicated diverticulitis, which is the middle row. Some people will get complicated diverticulitis and then have uncomplicated diverticulitis. And some people have the other way around, will have uncomplicated diverticulitis that will go into complicated diverticulitis. But majority of the patients will stay on the middle path of having uncomplicated diverticulitis and staying on that path. And the risk of that is about 20%. So initially we thought that 20% of the patients with diverticulosis will get diverticulitis. But that's not true, it's only 5%. And of those patients who do get the first episode of diverticulitis, 20% will get another episode within the next 10 years. So again, suggesting that not everybody with diverticulitis will have a subsequent episode of diverticulitis, but that is what everybody wants to know. And the challenge is we can't predict who will get it and who won't. So that was kind of the first part of the talk of just talking about the pathophysiology of diverticulitis, complicated and uncomplicated diverticulitis, and how the progression happens, and the fact that not everybody with diverticulitis will have a complication from it, or everybody with diverticulosis will necessarily have diverticulitis. So with that background in mind, we'll kind of talk about some basic questions that come up in usual daily clinical practice that providers see in their offices and that I see in my office. So the first question is, and I apologize for the slides format got a bit out of sync. So first question is, does every patient with diverticulitis need antibiotics? Conventionally, we've been taught that if you have an infection, you need to give antibiotics. It's been ingrained in our psyche, in our medical management, and in the patient's mental landscape that that's what the first thing is to do. Infection, antibiotics. So that's one big question. Then every patient with diverticulitis needs to have a colonoscopy, which I get a lot of questions on and patients ask when the providers. And then no discussion about diverticulitis is complete. We talking about nuts and seeds, and more so since we're in Iowa, corn, and then the role of high fiber. So we'll kind of talk about these three different questions and how we manage them. So this is the most common thing, that a patient has pain, they call into office and they say, well, let's get a CAT scan, because it sounds like it's something going on. And then they get a CAT scan, it shows some diverticulitis and inflammation, and the patient shows up in the office and in clinic. And then these are the first few questions that kind of have to be addressed, that every patient with diverticulitis needs antibiotics. And for years, that was the standard teaching, that if you have an infection, you need to be on antibiotics. But all of that in the last 5 to 10 years has been starting to be questioned, as we understand that maybe diverticulitis is not necessarily an inflammatory condition or an infectious condition. So again, the more we learn, the less we know. So just referring back to that. So this is from the American College of Physicians, which is a fairly reputable organization, and this is from 2022. So in the last 3 years, they suggest that clinicians can initially manage select patients uncomplicated diverticulitis without antibiotics. However, it's a conditional recommendation, meaning there's some caveats to that, and the evidence of low certainty, so it's not great evidence. Yet, to get to this point in a guideline from an association of this magnitude, there obviously has to be some evidence, and obviously there was enough evidence to make this recommendation. In lines with this, the AGA is the American GI Association, and again, their best practice advice, again, which is like a soft recommendation, is that the antibiotic treatment can be used selectively rather than routinely in immunocompetent patients with mild uncomplicated diverticulitis. But if you look at the words, all the adjectives are very non-specific, selectively rather than routinely, and mild uncomplicated. So how do you define mild and how do you define selectively? That is open to interpretation, and that's kind of a bit challenging, because as physicians, we like to have things more black and white. Either the hemoglobin is high or low, or the A1C is high or low, or normal or abnormal. But these kind of recommendations are very non-specific. Again, they talk about who should get diverticulitis or who should get antibiotics. They talk about patients of comorbidities who are frail. Both of these things are relatively subjective. It's hard to measure frailty objectively, and comorbidities is a very broad term. Somebody can have diabetes that's well controlled and hypertension that's well controlled, or somebody can have really uncontrolled blood pressure or bad coronary artery disease. All are comorbidities, but how does that really transfer into actual objective evidence to recommend antibiotics? So a lot of subjectivity, and that then comes to makes more challenging decision-making processes, that how do you decide in select patients, not routinely, maybe use antibiotics. So all adjectives that are not really very objectively measurable. So it's like saying how long is a piece of string. Well, nobody really knows how long a piece of string is, but we have to make clinical decisions based upon these subjective decision or evidence. So in summary, again, not to give everybody a headache of what to do, is there is a growing body of evidence to suggest that diverticulitis can be managed antibiotics or without antibiotics, and not everybody needs to have antibiotics, especially in uncomplicated diverticulitis. But I think there's a lot of obstacles for that to become mainstream, and maybe when I give this talk 5 years from now, it will be changed and everybody will not be giving antibiotics. But I think the biggest obstacle is the patient's psyche of being this ingrained in their minds that everybody has to be on antibiotics, they have an infection, and if you don't give them, they feel they're not being treated, and that just creates more anxiety and frustration. Then the worst thing happens if the antibiotics are not given and it gets worse, which it can totally happen. It can even happen when they are on antibiotics. Then the patient gets even more anxious or frustrated, feeling that they're not treated or mismanaged. So I think a lot of things will have to happen before that becomes standard of care. But for now, at least there is evidence to suggest that everybody doesn't have to be on antibiotics. Yet most of the people will get them. So then more specifically, then once you have diverticulitis, does everybody need to have a colonoscopy? And that's pertinent to me because I do colonoscopies also, and I do surgery for diverticulitis also. So that question, for something that's relatively simple, the data is divided. We don't have good evidence. It's not one that the evidence that we do have is not that great. And it's unlikely that it'll ever really be good evidence to support such a decision-making process, because it's very hard to do a good study that can scientifically prove beyond doubt which is the better of the two. So again, we go to the literature. Again, these are practice parameters, meaning a lot of experts, people have looked at the data and looked at evidence and say what they think is the best practice to do. And they again recommend that after the first episode, if not had a recent colonoscopy, they should probably have one. Again, it's a strong recommendation, but on low quality evidence, which means that they think they should do it, but they can't really prove it. But the caveat of that is, how do you define recent? Recent 1 year, recent 3 years, recent 5 years? Again, it's like how long is a piece of string? We don't really know. Same thing if you look at a meta-analysis, they say maybe people do not need a colonoscopy after an episode of uncomplicated diverticulitis. It is pretty clear that people with complicated diverticulitis still have a risk of colon cancer and should have colonic evaluation. So maybe a bit easier for complicated, but still not very good data for uncomplicated. Again, it's the same thing, looking at a large number of studies, what's the best thing to do, and we don't have a good answer for that. So again, questions like maybe, maybe not recently are all adjectives that are very non-specific. And again, the rationale for the colonoscopy is that we don't want to miss colon cancer. That is the colon cancer causing the inflammation or mimicking an episode of diverticulitis. That's the reason why we need to do the colonoscopy. We do know diverticulitis does not cause cancer, but we do know that cancer can sometimes mimic inflammation or symptoms of diverticulitis. So that's why it's a high stake thing to know that does the patient really have cancer instead of diverticulitis. Yet there is no evidence to support one way or the other. So in general, I kind of put it to, it's a decision-making process that involves the patient and the provider, and it depends upon clinical judgment. So it's not a black and white yes or no thing, and the patient has to be involved in it. Some people are more reluctant to have a colonoscopy, and some patients are more reluctant not to know. And you kind of have to figure out where that patient fits and what category, and then you make a mutual decision. In general, if they've not had a colonoscopy within 2 years, I do recommend they have a colonoscopy, and most people will agree to that. If they've had one within 1 year, I think it's reasonable to wait it out, and if they've had one more than 3 years, I think it's definitely reasonable to do a colonoscopy. But this is just based on opinion, and some patients are very nervous. They want to know if they had a family member with colon cancer. They're more likely to be wanting to have something done as compared to somebody who's heard somebody had a complication from a colonoscopy. They are more reluctant to have one. So that's kind of how I practice, and I think that's based on some degree of evidence and logic. Patients with complicated diverticulitis, if they had an abscess, if they had a fistula, anything that's more than just uncomplicated diverticulitis should have a colonoscopy. I don't think anybody disagrees with that. So again, one thing that everybody wants to know, that nuts and popcorn cause diverticulitis or diverticulosis, and if they avoid eating that, is that going to prevent it from happening? And this, again, it's like the antibiotic thing. It's somehow ingrained in the mental picture of the population that nuts and seeds cause diverticulosis and diverticulitis. And the logic is that the seeds or the skins will get stuck in the air pockets, and then they'll get blocked, and then they'll get infected. And for something that makes sense, it's not true. That's not how diverticulitis happens. Yet everybody kind of believes in that. So the evidence that does avoiding nuts or seeds cause diverticulitis does not exist. There just does not happen. In fact, there's contrary evidence to that people who eat high fiber diet, who eats nuts and seeds, actually have a lesser incidence of diverticulitis and diverticulosis. So it's almost contradictory to what we think. And yet, believe it or not, I had a patient today in clinic who told me that whenever he eats popcorn or seeds, he gets diverticulosis symptoms. So again, in that situation, I think it's a mutual discussion with the patient. What I tell everybody is that if you eat something and eat it in moderation, and if you eat something and it bothers you, then don't eat it. And everybody is different. I mean, there must be some people who have some irritation from nuts and seeds, and maybe they shouldn't eat it. But holding it on as a hardcore fact, I think, is unreasonable. And some people don't eat salads for years because somebody told them they shouldn't eat anything with nuts and seeds. And I think that may be extreme. So a balanced approach with mutual discussion with the patient is usually probably the best way going forward. So for all the choices we have, we talk about fiber, we talk about dietary fiber. Most American diets will not have the amount of recommended fiber. The recommended dose of fiber is 20, 30 grams a day. Most diets will not have it. Lettuce on a hamburger is not fiber in your diet, which a lot of people believe it is. And then in that case, nutritional supplements that are available over the counter are all very acceptable. None of them that I know is better than others. It comes down to patient preference, and some people like one over the other. But in general, the high fiber diet is recommended. That is the only thing that has been felt to decrease incidence of diverticulitis and diverticulosis, especially after the first episode, despite the lack of good evidence. So one thing, again, everybody asks about probiotics. That's another thing. And then some medications like mesalamine and rifampin have been talked about as potential therapies to prevent diverticulitis once you've had one. And despite the billion-dollar industry around it, there actually is no good evidence to support either one of these or either of these choices. So probiotics for sure, there are 1,000 probiotics, and even among the ones that have been studied, none have been shown to be effective in preventing diverticulosis. Same thing goes for mesalamine, which is a drug or medication we use for some inflammatory condition, and rifampin, which is another medication, or rifampicin that they use for bacterial overgrowth. All of those have been studied in small sample sizes, and none have been shown to be effective in managing or preventing diverticulitis. So what I do in my practice, I talk with the patients and kind of get a sense of what they want to do. If they want to try it, probably I don't discourage it. I think it's reasonable to try it. They can try regular yogurt, they can try Greek yogurt, or if they want to spend the money on probiotics, I think it's reasonable. And part of it, I think, comes down to paying attention to their diet. I don't know if the fiber in itself makes a difference or the probiotics, but if they're more involved in their care, kind of like a Hawthorne effect. Once you pay attention to something, things tend to get better. So I think this is just some kind of secondary Hawthorne effect. And then once you're more aware of what you're eating and what you're doing, and more aware of your body, you're more likely to take better care of it, and that's why people get better. So I think that again is never going to be proven, but it does make sense in prevention of these symptoms. So now we'll switch gears and talk about surgery the next 10 to 15 minutes. So we talked about the overall complicated and uncomplicated diverticulitis, and then we talked about some of the common themes that we come up in the clinical practice and outpatient setting, who gets antibiotics, who needs a colonoscopy, and the role of dietary modification. So once you've done all of that, then the question is, we've done all of that and still the patients are not getting better, then how do we decide who gets surgery? So like we talked about, we have complicated and uncomplicated diverticulitis, and we'll stay on the theme of uncomplicated diverticulitis since that's more complicated than complicated diverticulitis. So this again, same person that's been seen in the office, in the primary care office, now is in my office wanting to know what the next step is. And obviously the questions that they want to know, will they need to have surgery? Will this happen again? And all the things that go with it. So the biggest thing or the biggest myth that we have about diverticulitis or uncomplicated diverticulitis is that if you have one episode of diverticulitis and you keep on having episodes of diverticulitis, the bowel wall will get weak and the bowel will perforate and something catastrophic will happen. And when that happens, they'll have to have emergency surgery, and then they'll have to have a colostomy or a bag. And when you put it like that, that sounds terrible. If you tell a patient that, it puts fear in them, because nobody wants to end up like this with a bag and a big incision, which is understandable. But the issue with that is that this is not true, that uncomplicated diverticulitis does not turn into complicated diverticulitis with perforation as often as we think. That's what we used to think, but that is not correct. But again, this has been kind of ingrained into the mentality of the providers and the patients, which causes the greatest distress. And that's where they have to be educated and kind of talk through about what the incidence and significance of uncomplicated is and how often this may or may not happen. So the risk of perforation or developing complicated diverticulitis after an episode of uncomplicated diverticulitis is overestimated in the literature. All the people with just like the incidence of diverticulitis in patients with diverticulosis was overestimated. Similarly, the incidence of diverticulitis causing bad complications has been overestimated. Again, the reality, like we talked about, most people who will have diverticulitis will stay on the middle path of just having uncomplicated diverticulitis. The path of having uncomplicated going into complicated is only 4%. So that's much, much lower of it. And that's where the education comes into play and kind of explaining patients and walking them back from that mind frame that if they keep on having uncomplicated diverticulitis, it's going to get worse. So what causes recurrent diverticulitis? Once you have it, what will cause it to keep on happening? And these are some of the risk factors we know of. None of them are unfortunately totally modifiable, like young age of onset, severity of the episode, how much of the colon was involved, family history, smoking, gender, and obesity. All of these probably only smoking and obesity are modifiable. So it's a lot of what we do or what I do when we talk to these patients is educate them and kind of explain that we don't understand how to prevent this, but these are the things you can do. And even if you do them and the diverticulitis does not get better, if you end up having surgery or needing surgery, you'll be in much better shape because all of these risk factors also affect how your outcome happens after surgery. So that sometimes motivates them to kind of make these lifestyle changes and try to get into a better. So in summary, we talked about this slide in which multiple episodes of diverticulitis can lead to complicated diverticulitis and ending up with this. That is the myth, but the reality is that the risk is low. It's not zero, but it's much more lower than what we think it was. But the factors affecting it are not totally well understood, so it's hard to modify. But the risk is probably different in every different patient. So it's not that the risk is the same. And that's where we'll get into tailored approaches and individualized treatment of diverticulitis. So that's where this one-size-fits-all approach comes in, that even though it's uncomplicated diverticulitis, it's one condition, the same approach for one patient does not necessarily work for the next patient. And that's, believe it or not, that's most of the time when I talk to these patients, I spend talking about is that they have to figure out what's right for that particular patient and not what happened to somebody who lived next door or their brother they once heard about. So that's probably the cornerstone of the surgical decision making, that it has to be individualized and tailored. And that's because the disease is the same disease is different. So in a 45-year-old gentleman who smokes a pack a day, the previous surgery for a splenectomy, who had the BMI of 35 and has had a couple of episodes in 5 years, correct, is uncomplicated diverticulitis, but that is very different from a 60-year-old gentleman who is otherwise healthy, is fit from a BMI standpoint, and is missing work from his diverticulitis. So same disease process for the most part, but very different patients. And I think that's, as providers, that's where we have to counsel and educate the patients and kind of tell them what they need to do and what to worry about and what not to worry about unnecessarily. For the first patient, I think lifestyle modification, including avoiding cutting back on the smoking, losing weight, and doing dietary modification is absolutely the right thing to do. On the other hand, he may say, this is the worst thing that's ever happened to me and I want to have surgery. It would not be wrong to offer him an operation, but then there'll be a lot of caveats for all the risks that go with it and what they need to be aware about. As compared to the other patient, I probably would be more likely to offer him an operation. Yet, if they said, you know, it is bad, but it's not that bad, I can live with it, not doing surgery is totally acceptable as long as the patient understands the risks. A lot of counseling, a lot of explanations of what needs to be done and what can happen. So going back to the guidelines, so these are from the American Society of Colorectal Surgeons, the national organization that most colorectal surgeons belong to. And this is actually almost 10 years old, from 2014. But their recommendation is the decision to recommend elective colectomy after recovery for uncomplicated diverticulitis should be individualized, meaning it's not a one-size-fits-all. And what is very interesting is that when I started training, which is a decade or so before this, there actually was exactly the same slide that says that patients who have more than 2 episodes of diverticulitis should have surgery. So it clearly shows that the more we understand, the less we know, because say to individualize treatment is it sounds good, but it's very subjective. I mean, how do you individualize every single patient when every patient just wants to know, do I need to have surgery or not have surgery? So for something that's so simple, it is a much more complicated and nuanced discussion, but that's what it kind of comes down to, that you have to figure out what the right patient gets the right operation. This is from the AGA also, which is another large organization for 2020. And obviously, it was based upon number, why they said that should not be based on the number of episodes. So having the current episode of diverticulitis does not mean you need to have surgery. And I think that's one of the key points that people need to educate our patients about, that they shouldn't be focused on the number. Now, if you have 5 episodes in 2 years, that is obviously more symptomatic versus 2 episodes in 5 years. That's much different. So that's where the nuance and the subjectivity and the judgment comes in. So this is kind of where it kind of boils down to. I think we only have a couple more slides and kind of on time, and I'll spend some time on this. So when we make decisions, these are the two main factors: that is the patient, the clinician, and I think the third thing is the evidence. So that's how they kind of overlap. So we have evidence of certain things. We know that everybody with diverticulosis does not get diverticulitis, and everybody with diverticulitis does not necessarily need an operation, and everybody with uncomplicated diverticulitis does not all of a sudden develop perforation and gets very sick, what some people do. That's what the evidence is, and that's one bucket or one area. And then it's the clinician, based upon their experience and the evidence and what our talking to the patient. But I think the patient is just as important in this decision-making process, is that what's their lifestyle like? Like if somebody who's 45 and has an active job and travels a lot, for them, they say, well, if I have an episode of diverticulitis while I'm traveling, that can be crippling for me. So that patient will be very different from a 70-year-old person who's retired, who says, okay, I get an episode of diverticulitis, I have some pain, and I take some medication and I'm okay. So again, same disease process, but very different patient. Then it becomes down to their goals and even resources. Some people can't take time off work to have the surgery. Surgery, we'll talk about a bit. I mean, it's an investment of time and energy, and some people just can't do that. Another thing that's not mentioned here is their mental makeup. If somebody knows somebody who's had diverticulitis and had a bad outcome, that person's mental makeup is very different from somebody knows somebody or who has a neighbor who had surgery and had a good outcome. And those things you can only tease out with talking to the patient. They'll probably have AI and algorithms to figure all of this out, but in the end, the algorithm will just give you a probability. The reality is that you have to talk to the patient and figure out exactly what is right for them, is what we have to do, which is where no algorithm or no AI formula will ever be better off. But these are the two main things that we kind of talk about to make a decision and find something that's mutually agreeable. I have to admit, most patients are okay, actually appreciate this. There is a subset of patients who say, well, you're a doctor, you tell me what to do. And I still have never figured out a good answer to that question other than just educating a bit more. And I try to kind of stay away from that kind of paternalistic attitude or patriarchal attitude of telling them what they should do. And part of that is that the recovery of surgery is significant. There is morbidity to it. And if they have a complication, I don't want them to feel like they got forced into something they didn't really want to do. So something that, again, can be challenging, but definitely what the discussion and gives some context. So the decision of surgery, how do we decide when to do surgery? The surgery should be based upon the risk of surgery, the frequency of episodes, and the severity of the disability and the patient preference. So all of those things are critical in the decision-making process. So briefly about surgery, I won't go into the technical details, but it's the surgery, what I tell everybody, but just so they understand what's involved. It's a 4 to 6 hour operation. They're 4 to 6 days in the hospital, and there's a 4 to 6 week recovery. Everybody's a bit different, but that number is kind of helps them give some context of it. And whenever we do the surgery, there's all the risk that they may have to have a colostomy or a bag. That's usually temporary. That risk is not high, but it's not zero. And then there's always a risk of having a permanent colostomy or a permanent bag, which again is very low, but just not zero. So that's where you have to kind of balance all of the different factors of surgery and not doing surgery to the patient and giving them the whole perspective. Once they kind of figure out all these different options, I think they can make a much better informed decision about whether to have surgery or not. And then ultimately, it does come down to the patient. The same patient can have 1 or 2 episodes of diverticulitis and feel that it's debilitating and they want to have surgery. And then the next patient may have the same symptoms, it's identical, and feel that they can tolerate it and would not want to have surgery. So that's where the decision has to be a mutual shared decision-making process, which is now very acceptable. It happens in cancer all the time, and I think it's just an important benign disease. So we're almost done. So just to summarize the take-home points, again, thank you for everybody coming and listening in the lunch hour. That diverticulitis is a disease spectrum. It's not just a one-size-fits-all disease. Some people will have diverticulosis. A smaller number will get diverticulitis, and of those, even a smaller number will have complications, and most of the patients will have uncomplicated diverticulitis. But there's a lot of back and forth. So that's one big thing. Next thing is everybody does not need antibiotics, even though everybody does get antibiotics and probably will keep on getting antibiotics at least until there's a major shift in the management and the paradigm of that. And the key thing that to remember that it's not a one size fits all. What may be the same exact disease in one patient does not mean that the same decision would apply to the next patient. So everything has to be worked out on a one-to-one basis, and that's where giving education, explaining everything to the patient is very helpful, so they kind of make an informed choice, because we don't know the right answer. I don't expect them to know the right answer, but I think together, working together, we can come up with the right answer, which is the key thing. So with that, I'll end. Again, thank you again for coming. This is my contact information, and we'll go back on these slides. This is the Mercy General Surgery Clinic. We're a group of 3. Dr. Ahad is our bariatric and foregut surgeon. Dr. Brad is our does everything surgeon, and there's myself, the colorectal surgeon. We're always happy to be reached out to. Our phone numbers are at the end of at the bottom of the screen, and everybody knows Meg. When you call that number, just ask for Meg, and she'll figure out what needs to be done. Again, thanks again, everybody, for joining, and everybody in person and everybody online. We'll open up to questions. Again, don't feel forced to ask questions, but if you do, I'm happy to answer them now or anytime afterwards. Where is the QR code? Next on the get the credit? Is that the next slide? I will. Which one is that? Right here. This one. Okay. Meg will go over this also. These are the upcoming talks. So Brad is one of our partners. He's talking about reflux disease. Great.